today's topic, I always kind of like to mix it up a little bit. I think that last time I was here, we talked about congestive heart failure. We talked about, stress testing. But today I wanted to do two things. I wanted to spend the first half of the lecture talking about integrated rheumatology. And why do I call it integrated? Is because the theme is rheumatology is not just a disease of the joints. It affects almost every organ in the body. Of course, thinking about diseases like rheumatoid arthritis, like a lupus. And I really wanted to show how a rheumatological disease can affect the lungs or the heart. You never know. So integrated rheumatology. And I really wanted to spend a lot of time talking about some of these biologics and drugs that can get very confusing for the boards. And then another topic I feel goes under the radar, but I've been seeing a lot of questions about that throughout the years is the adrenal gland, and I want to focus about primary adrenal insufficiency and really focus not only about, how do we diagnose it, but also how do we treat it. So those are going to be the two things that we're going to be talking about today. So when we talk about integrated rheumatology, for those who know me, I always love starting off with a question. It's going to be the best. So let's talk about this 56-year-old woman is evaluated during a follow-up visit for persistent rheumatoid arthritis, persistent RA. She was diagnosed with this condition about a year ago. She began treatment with methotrexate. She takes 20 milligrams weekly. It's an appropriate dose. Hydroxychloroquine, 400 milligrams a day, which is also appropriate. And something called etanercept, which is the TNF inhibitor, that was added about 6 months ago. For the past 2 months, she has had persistent pain and swelling in the hands and the knees, as well as increased morning stiffness that lasts up to 3 hours. Of course, for those of you taking your boards, one of the buzzwords that help determine if it's inflammatory versus non-inflammatory joint disease is the terminology morning stiffness, of course. And 3 hours is quite a bit of time. These symptoms interfere with activities of daily living. She's on prednisone 5 milligrams daily, and this was added around 4 weeks ago and has only provided modest benefit. Her medical history is significant for osteopenia, and I'm sure being on 5 of prednisone is not helping that. She also takes alendronate, which is a bisphosphonate, probably because she has a high risk of developing osteoporosis and she has osteopenia. And she takes some calcium and vitamin D as well as folic acid because she's on methotrexate. On exam, vital signs are normal. Range of motion of the shoulders is decreased, and there are nodules on the elbows bilaterally, and bilateral synovitis of the wrists are noted. So nodules on the elbows are very common when we talk about people with rheumatoid arthritis, these rheumatoid nodules. There's bilateral swelling of the wrist, and the key thing is it's bilateral. So of course, when we talk about symmetrical arthritis really implies an inflammatory type arthritis. And of course, we know this patient has RA. Grip strength is decreased. There are small effusions on the knees, and there's some squeezed tenderness of the metatarsophalangeal joints bilaterally. So that just means you hold your hands out and you squeeze it, and ooh, that hurts. They get some labs, and her hemoglobin's 11, so it's low, probably having some anemia of chronic disease. Her leukocyte count is 8,000, ESR is elevated. Her rheumatoid factor is positive, and her anti-CCP antibody is also positive. And of course, when we talk about the classic combination to help diagnose RA, with the history and physical, of course, we think about rheumatoid factor positive. Rheumatoid factor is an IgM antibody, and anti-CCP is also a more specific antibody for RA. And the combination of rheumatoid factor being positive and anti-CCP really, not only would I say it's the peanut butter jelly of making the diagnosis as far as serology, but they probably have a really tough course. And it sounds like this patient's having a really tough course. They do radiographs of her hands, and it shows erosions. So it's a very aggressive disease, why it sounds like they're treating this patient with a biologic. Of the right second metacarpal phalangeal joint and at the base of the left fifth metacarpal bone. And unfortunately, diffuse periarticular osteopenia is also visible. We knew this patient also had osteopenia and is probably at a very high risk of having osteoporosis. Which of the following is the most appropriate next step in this patient's management? So of course, in the perfect world, I'll make you raise your hand. I'll call on you, or do an audience poll. But let's just walk it through this together. So, is the right answer going to be A, add infliximab; B, discontinue etanercept, switch to infliximab; C, discontinue methotrexate, switch to sulfasalazine; or increase to prednisone? So this is once again is someone who has rheumatoid arthritis, is on methotrexate, hydroxychloroquine, and a TNF inhibitor, and is doing worse, and was added prednisone at that time to kind of help out, and only had modest benefits. So which one do I kind of knock off right off the bat? My default for knocking off has to be D, add prednisone. So on the boards, anytime it says just crank up the steroids, chances are that's going to be the wrong answer. Steroids, they have some benefit, but they have a really long list of side effects. And of course, in this vignette, this patient already has osteopenia. This is not someone you want to keep on cranking up the prednisone. And we'll talk more about it. So really, anytime it says give more prednisone, chances are that's not going to be the right answer, okay? So D is going to be the wrong one. What about A? How about adding a TNF inhibitor to already having a TNF inhibitor? So, of course, anytime you talk about giving double biologics, especially in this case, TNF and TNF, that just sounds like the wrong answer. And in general, we don't give a biologic and what we call a small molecule together. This is going to be too much immunosuppression, and we'll talk about that in a second. So it leads you to B and C. So I would probably knock off C, discontinuing the methotrexate and just switching it to sulfasalazine, and someone with this being very symptomatic is going to be the wrong answer. It's not going to help out. There is something where it was, continue methotrexate and then maybe continue the hydroxychloroquine and add the sulfasalazine. Well, that's something called triple drug therapy. It may be an option. Triple drug therapy went head to head with being on a TNF inhibitor. And, it's cheaper and it has just as good, I would say efficacy as a TNF inhibitor. But this patient's already on a TNF inhibitor and, not doing poorly. So, just making this one-dimensional switch as in choice C is just not going to help the patient out. So if you didn't know which one to pick, I think your default answer is going to be B as in boy, but that made sense. Discontinue the current biologic TNF inhibitor and switch to another TNF inhibitor. And what's the take-home message there is that when we talk about biologics, TNF inhibitors in particular, that when you fail one, that one's not working for you, well, you could try another medication in the same class. And we'll even dive deeper in 1 second. So, if you want to try infliximab, if you want to try adalimumab, they all have similar efficacies. So just because you fail one doesn't mean you fail them all. And that seems like the right answer there. And I did mention about triple drug therapy. I put a couple of quick articles about that. Now, to be very specific, in general, not in this specific case, is that triple drug therapy is methotrexate. Triple drug therapy includes hydroxychloroquine and sulfasalazine, and it was non-inferior to a TNF inhibitor. In this case, the one they used was etanercept. And of course, you think about this, a lot of it's going to be cost effectiveness, that triple drug therapy is going to be a lot cheaper than putting someone on a biologic. So if you give both choices on the board exams, I definitely would think about triple drug therapy as long as there's no side effects that you have to worry about, because it's just so much more cost effective than being on a TNF inhibitor. But for this question, let's not get confused with what is the take-home message? That just because you failed one TNF inhibitor doesn't mean you failed the whole class. And that's why you could try one. In this case, it was etanercept, brand name Enbrel, and they wanted to try generic name infliximab, brand name Remicade. So, yes, I made this chart, and I put this here because what did I want to spend some time with in this case is all these different medications for rheumatology. And I'll try to go as slowly as I can. I know we only have an hour together, but the way I look at medications for rheumatology is that I break them up, number one, into anti-inflammatory and DMARDs. So when I think of anti-inflammatory, three broad categories jump to mind. non-steroidals, COX-2 inhibitors, and glucocorticoids. One thing that all three have in common right here, they're all rapid acting. When we think about non-steroidals and COX-2 inhibitors, when it's very, more like an arthralgia per se, not really arthritis. And if it's arthritis, it's something that doesn't have erosions. It's, it's not really affecting their quality of life. It could be giving some aches and pains. You could think about non-steroidals. The two organs you always have to worry about is going to be number one, the kidney. Non-steroidals can cause, an interstitial nephritis. When we talk about non-steroidals, they affect the afferent arteriole, could give you kind of like a pre-renal type picture. So you always want to watch the kidneys. You also want to worry about the GI tract, right? You worry about things like peptic ulcer disease that can lead to bleeding. So those are the two things I worry about with non-steroidals. When should you use a COX-2 inhibitor clinically or on the boards is when they state in the vignette needs to be on a non-steroidal, but you really worry about the GI side effects of peptic ulcer disease. Just because you're on a COX-2 inhibitor doesn't guarantee you that you're not going to get a peptic ulcer disease, in the right setting. If someone has a history of really bad ulcers with bleeding in the past, you may consider putting them on a PPI with the COX-2. But remember, COX-2 can definitely still affect the kidney. The claim to fame for COX-2 inhibitors is that it's not as toxic when we talk about the GI tract. Now, glucocorticoids also rapid acting. They do have benefit. And of course, the minute you start one, you want to taper them off as quickly as possible. When I talk about side effects of glucocorticoids, well, there's just not enough room in this whole PowerPoint to talk about side effects. But needless to say, of course, there's weight gain. There's going to be easy bruising of the skin. You could definitely have hypertension, diabetes, osteoporosis, just like in this patient over here. In the eye, you worry about cataracts, glaucoma, just swelling in general. So, of course, steroids, though you need it sometimes to bridge other types of DMARDs to kick in, you always worry about those side effects. So those are anti-inflammatories. When I think about DMARDs, I put DMARDs, disease-modifying antirheumatic drugs, into three broad categories. I put them into non-biologic, I put them into what they call small molecules, or biological DMARDs. So when we think about the non-biologics, they've been around for quite some time. And what do I know for the board exams is definitely going to be what are their side effects, So the most important non-biologic to think about for your boards, and someone especially with rheumatoid arthritis, is methotrexate, right? How does methotrexate work? It's a dihydrofolate reductase inhibitor, which is why when you give methotrexate, you want to give things like folic acid daily, or maybe in other cases, people use things like leucovorin. They could give that weekly, but folic acid daily, 1 milligram, sounds good to me. Methotrexate is a weekly, meaning once a week dosing drug, which is nice for compliance. It comes in 2.5 milligram doses or 7.5 milligram doses. And for rheumatoid arthritis, we use around 20 to 25 milligrams weekly, which is nice. Side effects, I don't know where to begin. Clinically, you want to start low and titrate up because of the fact that you get a lot of GI side effects. Before you start almost any of these drugs, including methotrexate, you want to rule out hepatitis B and hepatitis C, especially because the medication can be irritating to the liver. When you're on the medication, you want to check your LFTs, really focusing on the transaminases, AST and ALT when you're on methotrexate. You definitely want to check a CBC also every 4 months because you could get some cytopenias from that. It's inhibiting folic acid. You want to be careful of the drug when you have chronic renal insufficiency or chronic kidney disease. So it's something that people forget. You don't want to be on the drug if you have a very low estimated GFR in these cases. Routes, we usually give the medication orally. It can be given sub-Q and IM, mostly sub-Q, but I'll tell you one thing from a clinical perspective, it's hard to get approval for those drugs or even auto-injectors, and those are really hard to get approval for. But why would I give it, injectable-wise is because of the fact that they're having a lot of GI side effects. You probably get better bioavailability with it. So definitely think the cornerstone non-biological DMARD is definitely going to be methotrexate, and many studies will add on to methotrexate. The drug right below it is called leflutamide. It's kind of like the brother of methotrexate. Methotrexate is a purine inhibitor, while leflutamide is a pyrimidine inhibitor. And in rheumatoid arthritis, rheumatology, they use combinations of methotrexate, sometimes with leflutamide. But for your boards, when you pick it, if they need to be on methotrexate, but they're having side effects, such as maybe they're getting some lung toxicities. Truth be told, I don't see a lot of lung toxicity with methotrexate, though we all memorize it, but if they're having some kind of suspected lung toxicity, this will be a time to consider a drug like leflutamide. It is given daily. You do have to check your liver enzymes when you're on leflutamide. Azathioprine is also a very commonly used drug in rheumatology, not specifically rheumatoid arthritis. It's definitely dosed based upon weight. You want to worry for GI side effects. You want to make sure that they don't have bad cytopenias. You may want to check a CBC during therapy with the medication. Mycophenolate, everyone knows that as the brand name Cellcept. Usually for most rheumatological diseases, I'll probably be on the higher dosing of like 3 grams daily in divided doses. You definitely worry about GI side effects. You do want to check a CBC on it. Hydroxychloroquine, very weak anti-inflammatory. I think more about hydroxychloroquine probably in a lupus patient more than anything else. We all memorize the retinal toxicity that's non-reversible. Get a baseline eye examination when you're on hydroxychloroquine. Classic thing is to consider checking a G6PD level. These people who are susceptible could definitely get some kind of anemia when they're on this medication. Sulfasalazine, kind of part of that, what's it called? They call that triple drug therapy, but careful in sulfa-allergic patients. Not a very potent anti-inflammatory. Cyclophosphamide, definitely has its toxicities. It can be given initially through IV, then switched to oral. I think most of us memorize the hemorrhagic cystitis when they're on this medication. That's why we give a medication called Mesna when you're taking cyclophosphamide. It really does suppress your immune system. It's pretty rapid acting compared to a lot of these other ones. Methotrexate, as well as these other medications, takes a while to kick in. I think for your boards, you should know it takes at least 6 to 8 weeks for methotrexate to really kind of build up there, which is why we sometimes bridge with things like steroids, but we can't wait to take them off. So when you talk about the non-biologics, just feel free to, we add at least 3 of them sometimes. That's triple drug therapy to help out patients. But, if they're not doing well, you could consider adding a biologic or a small molecule. Let me kind of jump into biological DMARDs now. So biological DMARDs actually have 6 categories, and I'm sure down the line there'll be 7 and 8. These are such popular categories. And the 6 categories of biological DMARDs include TNF inhibitors, T-cell inhibitors, B-cell inhibitors, a bunch of interleukin inhibitors, and of course this list right here is not complete. Interferon inhibitors, and of course, what list is not complete without the word other? You know what I mean? So biologics really suppress your immune system. With no matter which biologic you're going to be using here, you probably want to rule out latent TB, and that's when you're probably going to do whether it's going to be a IGRA, interferon gamma release assay, such as a quantiferon gold, or in some cases something very traditional like a PPD. You also want to rule out Hep B and Hep C in these patients, but you could consider TNF inhibitors, and I put a bunch of them down here. The 3 classic ones are infliximab, given through the IV. Then, of course, there's adalimumab, which is Humira, and etanercept, which is Enbrel, and there's some other ones out there too. You want to be careful giving TNF inhibitors in patients with demyelinating disorders like multiple sclerosis. You do not want to give these medications to them, so please be careful. And if you don't do well on one, you could try another. It's not a class effect. T-cell inhibitors, the one out there is called abatacept, goes by the brand name Orencia. And on the boards, you may want to consider something like abatacept if they failed a majority of these TNF inhibitors, or if there's a contraindication to use a TNF inhibitor. Classic example would be someone with a demyelinating disease. Now, if it's not the T-cell inhibitor, it's going to be a B-cell inhibitor. B cells definitely make antibodies. B cells turn into plasma cells to make antibodies. So it kind of makes conceptual sense why we want to use them. Medications out there, the classic one is rituximab. Another one that's used specifically for SLE is belimumab, and please forgive me if I pronounce anything wrong. They're not easy. This is a medication goes by the brand name Benlysta, which is not used for lupus nephritis, but used for bad arthritis and skin disease. And that was a downside. We don't use it for lupus nephritis. It's a downside. We don't use it for CNS lupus. But that's really why, not to go out of order, these interferon inhibitors kicked in. One of them is called anifrolumab, which got the FDA approval for lupus, specifically lupus nephritis. So now lupus has two biologics you can use. One is a B-cell inhibitor and one is an interferon inhibitor. And of course, you really want to do a deeper dive into lupus to get more indications when you use these medications. Back to biologics, there are interleukin inhibitors. By all means, this list is not extensive, but there's IL-1 inhibitors. The classic one is anakinra. They'll use this for things like Still's disease. In fact, IL-1 inhibitors got also a use for people with inpatient gout. I said it, refractory to steroids, you could consider that. And then, of course, there's IL-6 inhibitors. The classic one is tocilizumab. I think COVID-19 put that on the map, didn't it? But definitely IL-6 inhibitors are now being used for things like giant cell arteritis. It actually got the FDA approval for polymyalgia rheumatica. And of course, we use this for rheumatoid arthritis. And maybe this is going to be a rheumatoid arthritis patient that failed TNF inhibitors, failed T-cell inhibitors, and they just wanted to try something that maybe an interleukin inhibitor. Then there's some really specific ones out there to get really specific indications. There are IL-17 inhibitors that got FDA approval for psoriatic arthritis and ankylosing spondylitis. There are IL-23 inhibitors specifically for psoriatic arthritis. And of course, usually we'll try a lot of these after you fail the classic biologic, which is a TNF inhibitor first. Last thing is other. There's something called repository corticotropin. It goes by the brand name Acthar. Acthar has two ways it works. A minor way that it works is that it represents a molecule very similar to the anterior pituitary peptide ACTH that will release endogenous glucocorticoid from the adrenals, but it also inhibits something called melanocortin. Melanocortin are receptors on the immune system. So Acthar, which is the name of the brand name of the medication, does act like a biologic. And it's FDA approved for diseases such as rheumatoid arthritis, dermatomyositis, and even we use it in people who have kidney disease like nephritis. And then if it's not going to be a biological DMARD, there's something called small molecules. Their claim to fame is that they're oral medications you can take by mouth, but they're just as potent in suppressing the immune system as a biologic itself, So treat them like biologics, rule out, latent tuberculosis, check Hep B, check Hep C. And the ones out there are going to be brand name is Xeljanz, that's tocilizumab, So there are three ones out there, and if you fail one, you may respond to another. But the key teaching point here, everyone, is that we do not combine biologics and small molecules together. We do not combine different categories of biologics together. You pick one, because you're really going to be suppressing the immune system quite a bit. So commonly, where the combinations we see is a non-biologic combined with a small molecule, or a non-biologic combined with one of these biologic in one of these categories. And it is confusing because many of these do have very specific indications, but at least I wanted to give you something to help organize your thought. And I really, really, truly hope this is helpful. I could spend an hour on this slide, but I do have some other things I want to cover, and I already could tell I'm kind of like, I need to pick up the pace. But hopefully this is going to be something that you guys enjoyed listening to. So with that being said, let's talk about, this question. It says pulmonary because I want to integrate Sjögren's with pulmonary. So a 65-year-old woman with a 20-year history of Sjögren syndrome is seen for an abnormal CT, which is down here. And when I'm looking at this CT, it looks like she has a bunch of cysts over here. She has mild, non-progressive dyspnea on exertion. No fevers, no weight loss, no cough. On exam, vitals are normal. Lung examinations, clear lung fields, and Heart sounds are normal. There's no digital clubbing. Labs, hemoglobin solid. The following serologies are there. The A&E has a big titer. Positive double-stranded DNA, a positive SSA and SSV, which is anti-Rho and anti-Law respectively. PFTs have a normal total lung capacity at 98%. Vital capacity is normal at 88%. FEV1 is normal at 90%. The ratio is normal at 76. DLCO is normal at 85. She does a 6-minute walk. She's 65. Give her a break, But she walks 1,000 feet with a SAT of 96% at rest, 94 with exercise. That's about right for a 6-minute walk in a 65-year-old. So she's great. And this was a CT scan that shows just a bunch of cysts over here, and she does have a history of Sjögren's. So what is the next best course in this patient, everyone? Should we give her a surgical lung biopsy? I think that's a little aggressive in someone who is having non-progressive dyspnea, just doing well. PFTs are doing good, walking 1,000 feet. I just want to surgical lung biopsy. Should we immunosuppress her in this asymptomatic patient? I don't think I would do that. Would I perform serial CT imaging? That's really tempting. Maybe serial PFT, serial CT imaging. I think both of those are really tempting. Would I do a bronch with a transbronchial biopsy? I think if I was ready to start immunosuppression, I felt she needed to be immunosuppressed, I think I'd be a little more aggressive about that. But it's someone that you're painting a picture that, hey, she really is asymptomatic and doing well with good PFTs. I think most of us will say we're going to do what? Nothing. So the right answer is C. I think we'll just do some serial CT imaging, maybe consider doing a repeat spirometry, see if she's changing herself, getting worsening with symptoms, that's different. But 20% of patients with Sjögren's have pulmonary disease, and most of these patients are going to be asymptomatic with just having findings on chest imaging. So Sjögren's can definitely give you an interstitial lung disease, why I kind of put this here. And, when we talk about interstitial lung diseases, the ones I listed here are called idiopathic interstitial pneumonitis, meaning that, there are people who could have all these crazy lung disease, but they're idiopathic. But because she has Sjögren's, we can't use the word idiopathic. I really want to pound home the point that when you have a rheumatological disease, when you have a connective tissue disease, you could have any of these findings that we see in these idiopathic disorders, but they're not idiopathic. So Sjögren's can give you any of this non-specific interstitial pneumonia, usual interstitial pneumonia, organizing pneumonia. If it's idiopathic, we call it COP, cryptogenic organizing pneumonia, but because this patient has Sjögren's, it's not really cryptogenic, it's just an organizing pneumonia. So what are we looking at here? With all these little cysts, this is not something I need you to dwell on, but this finding of having a bunch of cysts in the setting of someone with Sjögren's is what we refer to as follicular bronchiolitis, some diffuse random cysts of various sizes. And this is on a continuum with something that we call LIP, which is written up here, lymphocytic interstitial pneumonia. The difference is that when you have this LIP, you may have a bunch of cysts, but you'll see a lot of ground glass. And these patients are pretty symptomatic at that time. And I think I would change my answers on my workup if I feel I needed to treat this patient with steroids or under immunosuppression, but just not in this case. So when we do consider using therapy immunosuppression, of course, would probably use steroids first. And I would consider using medications like Celsep, mycophenolate, or azathioprine if I want to actually help taper off the steroids or they're not doing well on the steroids. And if they're refractory to it, a lot of these rheum diseases are antibody producing. So when we talk about the lungs, for tough cases, we may use a lot of rituximab because it's going to work on those B cells, inhibit those antibodies, and that would be something I consider. If this patient is developing pulmonary fibrosis, which there's no indication there's pulmonary fibrosis, and you're going to ask me, how do you know? If I see honeycombing, which is kind of like these stacked cysts, which this patient didn't have, they were starting to develop fibrosis. This is not idiopathic pulmonary fibrosis because this patient has what? Sjögren's. If they didn't have Sjögren's, you could call it idiopathic, but this is going to be pulmonary fibrosis. And there's a medication called nintedanib, which I would know for your board exams. Nintedanib goes by the brand name Ofev. It got the FDA approval for any type of interstitial lung disease that is just progressing to fibrosis, a kind of progressive phenotype. And this medication is not going to be the anti-inflammatories that we're using up here, such as steroids or mycophenolate or azathioprine. Nintedanib is an antifibrotic, and its claim to fame is that it really slows down the progression of the decline of the forced vital capacity. So the vital capacity is going to be going down pretty quick in these patients. This medication, nintedanib, that got the approval for all these ILDs with this progressive phenotype, it slows down that decline in the FVC. Of course, this drug has many side effects, such as diarrhea and more diarrhea. And I put this picture here because I mentioned that this diffuse, this follicular bronchiolitis over here is a continuum with something called LIP, and now you could really see just a bunch of cysts, but everything else looks good. But look at this picture here, everyone. Bunch of cysts, but look how that ground glass. So this is kind of LIP here, and this patient does look like they would be more symptomatic over there. So what did I want to talk about here, everyone, is Sjögren's. That's what you're going to have on your boards. It's a chronic inflammatory disorder, getting diminished lacrimal, which is always going to be the eyes, and salivary gland function. Sjögren has two forms, everyone. It has a primary form that's not associated with other diseases. It's the primary form I always worry about. Are they going to be getting lymphoma, such as non-Hodgkin lymphoma? Are they going to get things like multoma? Or Sjögren's could be secondary to other diseases. And what's a very common rheumatic disease associated with it is rheumatoid arthritis, When we talk about, whether it be primary or secondary Sjögren's, it could definitely lead to a decreased exocrine gland function, and you get that Sika complex, which is the dry eyes. They call that keratoconjunctivitis, Sika. And Sika, by the way, is just the Latin word for dryness, just in case you're wondering, or a dry mouth, what they call xerostomia. Now, when we talk about the manifestations of whether it's a primary or secondary Sjögren's, you could have what they call glandular features or extraglandular. And these extraglandular is how I always say Sjögren's affects every single organ in the body. So you're going to ask me, well, what organs are you talking about? So let's get to those. But I did mention for the glandular features, there's that Sika complex, just to say it one more time. If you have the dry mouth, of course, xerostomia, you worry about dental caries. It happens up to 65% of patients. Oral candidiasis happens in quite a bit of patients. Dry eyes, of course, can be very irritating. Salivary gland enlargement, one of the classic ones we think about is parotid gland enlargements with Sjögren's, which is why Sjögren's can mimic things like sarcoid. It can mimic things like an alcoholic-induced cirrhosis. Alcoholic-induced cirrhosis gives you parotid gland enlargement also. And of course, you could have dry skin. So some of the glandular manifestations, you can see the dry tongue, why you think about the trips to the dentist. Parotid gland enlargement can be pretty obvious in some cases, or sometimes when you evaluate patients that have the big thick neck, it may be subtle and you may not notice parotid gland enlargement as much. When we talk about, extraglandular, I want to mention the skin. Things that you could think about can be cutaneous vasculitis that you see here on the bottom right. They could get Raynaud's. Raynaud's is not only seen in scleroderma, though we always think of it that way. It could be seen idiopathically. It could be seen with SLE. It could be seen with Sjögren's. You could get annular erythema that you could see on the bottom left. You could get erythema nodosum. It's not just only seen in sarcoid patients or inflammatory bowel disease. And of course, livedo reticularis, we know that's very nonspecific. And of course, I think that's quite often in my medical ICU in people with shock. But here are some of the extraglandular features. We mentioned today that people with Sjögren's can get interstitial lung disease. The one I showed you once again is that, follicular bronchiolitis spectrum with something called lymphocytic interstitial pneumonitis. Sjögren's could affect the GI tract. You can get dysphagia. It can cause pancreatitis, like an autoimmune pancreatitis. I know autoimmune pancreatitis has been associated with IgG4 disease. You can get peripheral nervous system, multineuritis multiplex. Always worry about non-Hodgkin's lymphoma, especially if you have a big lymph node in there. mean have a very low threshold to do a core needle biopsy. If it's negative, maybe consider doing an excisional biopsy. It's an autoimmune disease, so it's associated with other autoimmune diseases, like such as in the liver, primary biliary cirrhosis, anti-mitochondrial antibodies. For nephrology, it's associated with type 1 RTA. Type 1 RTA always affects the distal convoluted tubules. And of course, the heart can be associated with pericarditis, and joints, it can give you a symmetrical arthritis. It can give you a symmetrical arthritis also. And I put this CT here if anyone was wondering what honeycombing looks like. This is going to be honeycombing, and definitely people with Sjögren's can go on to develop pulmonary fibrosis with this honeycombing. This is when I would consider that antifibrotic nintedanib for a patient. Diagnosis, everyone. Of course, what do you suspect? If in the olden days, if you had an ophthalmologist right next to you, you could do what's called a Schirmer's test, looking for dryness of the eyes. More commonly, we think about during serological testing. Remember, ANA is not only seen in people with lupus. There are definitely other diseases such as scleroderma and Sjögren's can have a positive ANA. And you think of more specific antibodies like anti-Rho, otherwise known as SSA, or anti-LA, known as SSB. The gold standard, most accurate, would be a salivary gland biopsy. Usually they do a minor salivary gland lip biopsy, which is commonly performed in ENT. And, if I was going to treat someone for extraglandular Sjögren's, of course, I would think about steroids, and I would consider doing a biopsy before therapy. So let's talk about this 45-year-old woman with a 3-year history of systemic sclerosis. Presents to the clinic reporting increased dyspnea on exertion, dry cough, physical exam within normal limits. We're really referring to the vitals. She's saturating 96% on room air. She has perioral skin tightening. Lung exam reveals crackles at both bases. Cardiovascular exam has normal heart sounds. Extremities is notable for skin thickening extending proximal to her PIP joints, but there is no clubbing or edema. Labs, she's positive for anti-topoisomerase, otherwise known as SCL70 antibody. PFTs, the TLC is less than 80 at 68%, restrictive. FBC is low at 73%. FEV1 is relatively normal at 82%. The ratio is normal at 84%. DLCO is reduced at 62%. The TLC, FBC, and DLCO have all decreased, though, since previous sets of PFTs only 6 months ago. They do a high-res CT, and when I'm looking at this patient is having findings of fibrosis that are occurring in the lung. I could see some traction bronchiectasis over here, some subpleural reticulization, meaning that more like the spider web, the lines right above the pleura. So what medical therapy has demonstrated efficacy with the least adverse effects? So we have a scleroderma patient with pulmonary fibrosis. Which medication should we think about in these cases? Well, let's do this together. Cyclophosphamide has been used in scleroderma patients with pulmonary fibrosis, but definitely has side effects. Mycophenolate actually has data to be used in scleroderma patients with pulmonary fibrosis, maybe not so much side effects. And we also have another, we have the biologic rituximab that works on B cells. And of course, it does have side effects. It's not one of the more front things that we use in these patients. It doesn't have as much data, and it is a biologic. And pirfenidone is not FDA approved for people who have scleroderma, so that would be the wrong answer. It would be a little tricky if this was someone where they said nintedanib, which was OFIF from another place that did get approved for scleroderma, but not pirfenidone. So which one would I pick here? Seems like there's some active inflammation going on here. There's still some ground glass over here. That I would probably pick mycophenolate. So that is the right answer over here. And, there are a number of rigorous trials, talking about interstitial lung disease in scleroderma patients. Here's another picture of someone with honeycombing. And of course, these trials include comparing cyclophosphamide to placebo, cyclophosphamide versus mycophenolate, and even using the nintedanib, which is the antifibrotic versus placebo. And just to summarize this, because I know I want to go on to endocrinology, that mycophenolate, I just put the word preferred. This has been studied in patients who have symptomatic scleroderma patients with pulmonary fibrosis, declining PFT, such as this. This medication is, you start off probably in around 1.5 grams and slowly titrate up to 3 grams daily, would be the preferred agent. Cyclophosphamide was used quite a bit in the past, but because of side effects, that we don't use cyclophosphamide up front as we did in the olden days. And this is not a mistake, everyone. Tocilizumab, which is going to be the IL-6 inhibitor, actually got FDA approval for patients with scleroderma who have pulmonary fibrosis, who have the interstitial lung disease. And this is something to consider, maybe in someone who's going to be failing cyclophosphamide, mycophenolate, you could think about this medication. So for maintenance therapy, of course, it's hard to say how long you keep patients on these medications. We definitely know for sure mycophenolate can be continued for at least 2 years, and we'll reevaluate the risk and benefits of staying on the medication. Cyclophosphamide, you can start off with an IV, then go oral. Of course, a lot of side effects there. And for refractory disease, I did mention that this is where you could consider using things like rituximab, and this is not an error right here. There is some data about using hematopoietic stem cell transplant for people who have very bad fibrosis, and they're a scleroderma patient with progressive fibrosis. But this is, going to be last line. So the right answer here is CellCept. And let me talk about scleroderma as whole to really have you guys prepared for the boards. So I really want you to focus on the top right over here. So when we talk about scleroderma, that I put them in 2 broad categories. I put them in systemic sclerosis, systemic scleroderma, or localized. Now bear with me here. If you have localized scleroderma, it really implies there's only scleroderma on the skin. You don't have involvement of the internal organs. So really, when we talk about board exams for the internal medicine boards, they're really focusing on systemic scleroderma, not really localized. Localized only means the skin and only the skin. One of the skin lesions you could see in patients with localized scleroderma is called morphea, and sometimes you could have linear scleroderma. But what are the ones that we classically think about for your boards is called systemic sclerosis, systemic scleroderma, which is divided into limited. Many of you folks call that the crest syndrome. And of course, there's diffuse. Now, one thing I just can't say enough, and probably my take-home message for everyone here, is that, both limited and diffuse scleroderma can affect every single organ in the body. Limited doesn't mean you're limited to certain organs. Diffuse doesn't mean every organ. Limited and diffuse really refer to the scleroderma skin score, which is not tested on the IM boards, stuff rheumatologists do. But as the name implies, limited skin involvement, limited. Diffuse is diffuse. Of course, the organs more affected than limited are the crest syndrome. And in diffuse, they tend to have more cardiac and lung and kidney disorders. So when I think about systemic sclerosis, what are going to be some subtypes under that? There's diffuse scleroderma, limited. There's mixed connective tissue disorders. Remember, that's something that's called the overlap syndrome. The antibody associated with that is anti-RNP. And of course, what would rheumatology be without another category called syn scleroderma, which means, yes, you could have scleroderma without the skin findings. Go figure. So here's a picture of morphea when you have that localized scleroderma just to the skin. This is kind of a linear scleroderma over here, just localized. Limited scleroderma, please know the crest syndrome. It's a great acronym to use right there, because you're getting involvement of sclerodactyly, of course, because you're going to have Raynaud's and all these things. It's good to evaluate the capillary nail fold bed. Usually you want to see it in the top picture, nice, and you can really clearly see demarcated capillaries. But of course, when we talk about people who unfortunately do have limited scleroderma, you could see distortion of the capillary fold and nail fold bed. Antibodies I think about for limited, ANA followed by an anti-centromere. Diffuse, more extensive skin score associated with an anti-topoisomerase, otherwise known as SCL70 antibody. And as I mentioned before, greater risk for renal crisis, lung disease. And of course, the two things in the lung I worry about the most with scleroderma is interstitial lung disease and pulmonary arterial hypertension. And of course, they also can get cardiac disease. In the red box, I wish there was a drug that treats the skin involvement, just wonderfully, but there isn't. And it's really disfiguring, and it's really, these patients can't even move when they have bad skin involvement. They've tried methotrexate. Sometimes they use mycophenolate in these patients to help out with the skin, but it's not a magic treatment, and a lot of patients don't respond. And of course, when we talk about prognosis, most patients, are going to have poor outcomes the minute they have lung involvement, whether it be pulmonary fibrosis or pulmonary arterial hypertension. And other risk factors for increased mortality, more skin involvement, once again, heart and lung involvement is going to be there. And of course, if they get that scleroderma, renal crisis, and renal disease, that's going to be poor prognosis there. So with that being said, I'm going to try to go through primary adrenal insufficiency in 13 minutes. So I do want to say a few things. When we talk about primary adrenal insufficiency, the signs and symptoms really depend on a few things. The rate. How fast are your adrenals being destroyed? Is it acute, subacute, is it chronic? The extent of the loss of adrenal function. Is this someone where there's a partial damage to the gland? Is it a full gland has been destroyed? This is going to be important. And really another thing that's important is, well, what about those mineralocorticoids? Meaning, what about the aldosterone? When we talk about what really regulates potassium levels in the body, it's aldosterone. And of course, what does aldosterone do, everyone? It makes you reabsorb the sodium, and you dump out potassium in the urine, and hydrogen ion gets dumped out in the urine. So if you have, no aldosterone levels, you're going to have a very high potassium. You got to be careful, And of course, the stress. What kind of physical stress are you going under? Are you undergoing a surgery? Did you undergo a motor vehicle accident? All these things factored in will tell you what are your signs and symptoms of adrenal insufficiency. So the onset of adrenal insufficiency is often very gradual. I think many people assume you say adrenal insufficiency, it has to be an adrenal crisis. But many people go undetected because it's very gradual until, unfortunately, an illness comes up or some kind of stress comes up, and then you get the adrenal crisis. So when we talk about adrenal crisis, don't get me wrong, it's in bolded red. It is a life-threatening condition, and it really comes down to there's just not enough cortisol. So I put this picture here because when we talk about, the adrenal gland, there's the cortex, and of course there's the medulla. And we talk about, the cortex, it's subdivided into the zona glomerulosa, which makes aldosterone. The zona fasciculata is the biggest chunk here, and it makes cortisol, influenced by ACTH. And of course, you have the zona reticularis that makes the androgens, And of course, if you have an adrenal crisis, the main thing we think about is shock. I usually give this talk when I'm hanging out in the medical ICU. But as I said, you could have a gradual adrenal insufficiency before it leads into right adrenal crisis. So think about anorexia. You get some nauseated, vomiting, some poorly defined abdominal pain, weakness, fatigue, lethargy. And of course, now we're getting severe with confusion, of course, coma. So the most common cause of a primary adrenal insufficiency, otherwise known as Addison's disease, is autoimmune. So you get an autoimmune destruction of all the layers of that, adrenal cortex, which is subdivided into zona glomerulosa, fasciculata, and reticularis. And approximately 90% of patients are going to have antibodies to something called 21-hydroxylase antibodies. So that's going to be a nice little board poll right there. What antibodies are going to be ordered, or would you order? Those 21-hydroxylase antibodies. Now, 50% of people who develop autoimmune adrenal insufficiency develop another autoimmune endocrine disorder in their lifetimes, such as primary hypothyroidism. I think you're probably going to assume I'm thinking about a Hashimoto's thyroiditis. They have a lot of autoantibodies there. Primary ovarian insufficiency, hypoparathyroidism, of course, type 1 diabetes that have these anti-islet cell antibodies. And if you have a combination of primary adrenal insufficiency combined with any one of these, they call it autoimmune polyglandular syndrome. And a nice little pearl for your boards is if you have this autoimmune polyglandular syndrome, it's associated with the skin lesion vitiligo. So please, that would be a great question for your board exams. And also remember, because it's associated with other autoimmune diseases, why not celiac disease, which is a great topic on boards in general. And I know celiac disease was it anti-gliadin antibodies, anti-endomysial antibodies, anti-transglutaminase antibodies. These are IgA antibodies, by the way. So it doesn't surprise me. And the classic skin lesion with celiac is dermatitis or petiformis. So primary adrenal insufficiency can also be caused when you get a bad infection, infiltrated disorders like sarcoid, hemochromatosis, even amyloid, of course, unfortunately, even lymphoma. And of course, right here, I put some bilateral hilar fullness. And of course, in the right history, right physical, this could be a sarcoid patient. Metastatic disease involving the adrenals rarely leads to adrenal insufficiency, even if both glands are involved, just to mention that. But one thing I do want to mention, this is maybe more medical ICU, if you get bilateral adrenal hemorrhage, that of course that can present as an acute adrenal insufficiency. And you could consider that if it's unexpected hypotension develops. What would be risk factors for developing this? Well, if you're anticoagulating someone develops DIC, disseminated intravascular coagulopathy. Sepsis can definitely do that. If you have protein C deficiency, it can happen. And I put this here specifically just in case we have some listeners that just really love their USMLE Step 1. I don't know if anyone remembers Waterhouse-Friderichsen syndrome. I've always memorized it but never seen it. Is adrenal failure due to bleeding into the adrenal glands caused by several bacterial infections. The one that always jumps to my mind is people who have Neisseria meningitidis. So I had to put that one there, just had to. So clinical features, primary adrenal insufficiency is a life-threatening disorder that often presents with initially an insidious and gradual onset. So therefore making a diagnosis can be challenging. It may also present as adrenal crisis after an acute illness, or sometimes maybe you're initiating thyroid hormone replacement and you didn't realize the patient also had adrenal insufficiency, and that can cause it. And that's why rule of thumb is that you always replace the cortisol first before you replace the thyroid. And that combination of hypothyroidism and adrenal insufficiency, sometimes referred to as the Schmidt syndrome. And yes, cortisol first, then the thyroid. And when you work these patients up, since the problem is primary in the adrenals, ACTH levels should be high in these cases. And one thing we commonly think about, but it's not present in all patients, is hyperpigmentation. I think many of us know where I'm going with this. Think about the stimulation of melanocytes by high levels of melanocyte stimulating hormone, which is very similar to ACTH. And really that darkening, hyperpigmenting of the skin is one of those hallmarks of primary AI. So how do you work these patients up, everyone? Well, I would say 3 things for your boards. Number 1, check a 8 a.m. cortisol level. And remember, when we think about cortisol, it's diurnal. It's different in the day, different in the night. Cortisol is going to be the highest in the morning. So if you think you're deficient of it, it should be low in the morning. Then I would check an ACTH level to see if it's going to be primary or secondary. If it's going to be primary, ACTH levels are going to be super duper high. If it's going to be secondary, they're going to be low. And sometimes there is, if you want to do a more conclusive test, you could do what's called ACTH stimulation test. Many of you call it a cosentropin stimulation test in the right setting. I'll tell you the right setting is probably not going to be the medical ICU. So primary AI is confirmed by a combination of low serum cortisol, elevated ACTH levels, and that evaluation will include measuring some of these 21 hydroxylate antibodies we talked about. And you can consider CT of the adrenals, especially if you don't see or don't have a positive antibody and you're wondering if something else is causing the problem with the adrenal gland. So how do you treat them? Well, you're going to treat those with both glucocorticoids and mineralocorticoids. And that's going to be a key board pearl there. If they ask you, you want to give both. You want to give the steroid and the aldosterone. And the preferred glucocorticoid is hydrocortisone, because you could do that 3 times a day. And even though many of us will just default to saying, here's your prednisone, because you can use it once a day, it's more convenient. But the whole principle is that, cortisol is diurnal. It's going to be high in the morning, low at night, that you want to kind of mimic what your adrenal should be naturally doing. Be careful with over-replacement. Of course, these patients can develop a Cushing syndrome because you're giving them too much cortisol. And mineralocorticoid replacement is usually once daily. And the classic thing we use is fludrocortisone is what we use. So it's important that, patients can have a kind of a sick day rules. So unfortunately, if they do develop adrenal crisis, they should wear a medical alert tag. So if they were found down, the importance of them receiving steroids is such an emergency in these patients. And these patients should be prescribed an emergency kit with high dose steroids that can be given intramuscularly in these patients. And just to make sure that I don't forget to tell you this, always, if you're worried about hypothyroidism, please give the steroid first before you're going to replace the thyroid. I did mention earlier in my lecture there's something called the Schmidt syndrome, which is the combination of autoimmune adrenal insufficiency and autoimmune hypothyroidism, plus or minus type 1 diabetes. They call that the Schmidt syndrome. So with that being said, I hope no one's going to be upset, but can I just do maybe 3 questions? I know I love taking my time, but I really want to show you how you integrate this. So there's a 39-year-old woman who's evaluated for fatigue and abdominal pain for 3 months duration. She has lost weight 5 pounds during that time. She has no other medical problems and takes no meds. On exam, her blood pressure is 110/70 sitting, and it goes down to 90/60 when standing. Sounds like she's orthostatic. Her heart rate is 70 sitting, goes up to 88 when standing. Remaining vitals are normal. Her BMI is 19. She has intensely tan skin, that's even in bolded red, and hyperpigmentation of the buccal mucosa and palmar creases. It's hyperpigmented. Visual field testing is normal. They do some labs. Sodium is low, potassium is high. Sounds like there's no aldosterone. The morning cortisol is pretty low at 2.1. It's pretty low. And the ACTH level seems to be pretty high. Low cortisol, high ACTH, that is primary adrenal insufficiency. Patient is orthostatic and pigmented. Oh boy. Which of the following is the most appropriate next step in management? Let's do these together because of time's sake. Does this patient need a concentropin stim test to prove what's going on here? I don't think so. And I think, speaking to guidelines, when your morning 8 a.m. cortisol is 2 or less, that in itself, along with the symptoms, confirms the diagnosis. I don't think you need a stim after that. And this patient's symptomatic. It needs to be treated anyway. If I were to treat, I probably would use, a dexamethasone if I still was being very stubborn and I wanted to do an ACTH stimulation test. But I don't think you need to do one. I'm not going to go with A. I'm sorry. B, hydrocortisone plus fludrocortisone. I see manifestations of both aldosterone deficiency as well as glucocorticoid. You're really going to have to twist my arm not to do that. And this is primary. MRI of the pituitary, I don't think that's necessary. The ACTH level is going to be very high over here. There's darkening of the skin. There's no eye findings. I'm not going to pick C. Prednisone, once again, I need to address the aldosterone. I know some people will say, but isn't there a little mineralocorticoid with prednisone? There probably is, but just not enough, especially in someone who's hyperkalemic. Measure serum aldosterone levels. I don't think this is appropriate in this case. It seems insufficient. It's not as if the patient's having a Conn syndrome or anything like that. I got to pick B, everyone. I hope we're on the same page. And our answer is B. And I did mention already how to be treated. You want to use things like eventually hydrocortisone, kind of in 2 to 3 times per day, to kind of go with the diurnal variation of the glucocorticoid. And this one probably is going to be an autoimmune because that's one of the most common things that we see. And B is definitely the right answer here. Let's do 2 more. I think I can squeeze them in, everyone. 62-year-old man is evaluated in the hospital for several hours of nausea, lightheadedness, and back and abdominal pain. He underwent uncomplicated mechanical aortic valve replacement 3 days ago. He's been doing pretty good post-op until his current symptoms, which is nausea, lightheadedness, back and abdominal pain. He had a history of hypothyroidism in the past. Meds are unfractionated heparin because he just got some kind of aortic valve replacement. He's on levothyroxine for his hypothyroidism, and he has some pain meds and oxycodone. On exam, he is 99 degrees for the temp. His blood pressure is bolded at 80/50. That's not good. He's hypotensive and tachy at 110. Not tachypnic yet at 18. BMI is 26. Remainder of the chest exam shows clean, dry sternal wound. Cardiac exam reveals tachycardia and a mechanical S2 now because he has a mechanical aortic valve. There is no pain with palpation of the abdomen or low back, but his skin pigmentation is totally normal, so he does not have pigmented skin. All right. Labs, it looks like his hemoglobin is now 7.3, which is already low, and it was actually 9, so it dropped almost 2 grams. Leukocyte count is 11,000. PTT is elevated at 70, which is normal because patients on unfractionated heparin, which affects the intrinsic pathway. So the PTT is 70. Creatinine is 1.0, which is normal. Sodium is 130, which is low. Potassium is high at 6. And the cortisol is low at less than 2. Which of the following is the most likely diagnosis over here? So let me take a look at this. Is this going to be someone who just knocked off his pituitary apoplexy? Did he bleed into his pituitary? Well, I can tell you one thing. I'm sure this gentleman didn't have a Sheehan syndrome, which is seen in, of course, in pregnant in women after they deliver and you infarct. This is not pituitary apoplexy, anyone. I think the problem here is really focusing on the adrenals. Is this opioid-induced adrenal insufficiency? Probably not, because opioids don't really induce adrenal insufficiency, Is this an autoimmune adrenalitis? Well, I think the adrenals are gone, but does this seem like something that happened that was kind of building up? I would probably say no. I mean, the skin pigmentation is normal, and he never had any issues. I know he had that history of, hypothyroidism there, but, there's no indication that this is going to be an autoimmune adrenalitis, especially with the hemoglobin going down. Patients on unfractionated heparin. This really sounds like an acute bilateral hemorrhage. Suddenly post-op, he develops this. This kind of makes sense with the reasons what I said. I wouldn't pick anything else. So the answer here is going to be what? B as in boy, for all the reasons we talked about. So I know many of you are just waiting to get off, and I apologize. Can I just do one last one and we can call it a day? All right. So this is a 65-year-old woman is admitted to the hospital for fatigue and weakness over the last 1 to 2 weeks. Medical history is significant for hypertension, type 2 diabetes, and I couldn't resist it, everyone. You could roll your eyes, rheumatoid arthritis. I always like to integrate. I know we just talked about rheumatoid arthritis. For the past 3 months, patient has been treated with methotrexate. I always say it's the cornerstone. Unfortunately, prednisone. Because of inadequate control, what a surprise, they added a biologic TNF inhibitor and etanercept to the regimen, which was added 2 weeks ago. At that time, patient decided to just stop the prednisone because she was getting bruising of the skin. So current medications are methotrexate, which is a non-biological DMARD, a TNF inhibitor and etanercept, a CCB, amlodipine, folic acid because of the methotrexate, metformin, and aspirin. On exam, patient's blood pressure is 110/70 and 90/60 standing. Patient is orthostatic. Heart rate is 102 sitting and shoots up to 110 standing. Borderline orthostatic. Symmetrical synovial bogginess of the MCP joints and wrists are noted because her RA wasn't controlled. And once again, they got that morning cortisol level 2, remember 2 or less, really indicative of what? Primary adrenal insufficiency, especially if the ACTH is high. But no matter what, this is definitely adrenal insufficiency here, no matter what, Which of the following is the most appropriate management? Oh boy, this is interesting. So choice A is hydrocortisone. Choice B is hydrocortisone and fludrocortisone. Choice C is perform an ACTH stimulation test, which I already said, when you have such a low morning cortisol in someone who's almost orthostatic, and there's a smoking gun here, right? Why is this happening to the patient? Patient was on prednisone, and what did this patient do? Just stopped it. And let me ask you this, class. Is it good to just stop your steroids, stop your prednisone cold turkey? No, we all know we need to taper that out. Give time for the adrenals to kind of get back in there. But she stopped it immediately and then developed orthostatic issues. So I don't doubt that she's adrenally insufficient. So I'm not going to do a C, perform an ACTH stimulation test. I'm not going to perform it even after I give steroids over here, even though I would like to give steroids. So it really comes down to A and B. So which one do you folks think is going to be the right answer? Who thinks it's going to be A, just give the hydrocortisone? All right, I'm just kind of pretending that I'm seeing everyone. Who says it's B, give the hydrocortisone and fludrocortisone? And the right answer here, everyone, is going to be A. What? What did Dr. Raj just do? Why is it just A? Because when we talk about someone who is going to be taking steroids, what type of adrenal insufficiency do you develop? Do you develop a primary or do you develop a secondary? And the answer is, it's a secondary adrenal insufficiency. So if the problem is that when the pituitary sees all the steroids, it's not going to secrete ACTH. But the adrenal itself is still functioning. And when we talk about what's in charge of the mineralocorticoid, it's the renin-angiotensin system. So in this case, what do you really just need to replace? It's just the cortisol. So the answer is going to be A. So I put this right here. I apologize. I know you're mad at me. I put down USMLE Step 1 throwback. Remember, is that when someone is taking, steroids, that they are going to cause a secondary adrenal insufficiency affecting low ACTH levels. But the renin-angiotensin system is still activated, so there's no need to give mineralocorticoid supplementation at this time. So, what are my beyond the pearls for this section of primary adrenal insufficiency? Most common cause of primary adrenal insufficiency is still autoimmune adrenalitis, leading to progressive mineralocorticoid, glucocorticoid, and adrenal androgen deficiency. Glucocorticoid and mineralocorticoid therapy are required for primary adrenal insufficiency. Don't get tricked by my question. Patients with adrenal insufficiency require instructions during a sick day. Okay, and don't forget that medical alert bracelet they need to be on. And with that being said, I know I went over about 10 minutes. I really hope everyone enjoyed this. The rheumatology section and the endocrine section, they're both very high yield for the board exams. And I really, truly hope to meet everyone in person one day. Good luck, everyone. It was nice having you to stay on this whole time.
All right, Dr. Raj. So it looks like we have 2 questions in our Q&A window.
Oh, there we are. So one just says are SSA DNA and single-stranded DNA and double-stranded DNA always positive in Sjögren syndrome? Primary versus secondary Sjögren's, SS, or double-stranded DNA correlation? So the answer is no. Of course, right off the bat, when you say the word always, my answer is always no. It is unfortunate that in many of these autoimmune diseases, many of these rheum diseases, can you have the disease and be antibody negative any disease? The answer is yes. For example, rheumatoid arthritis. There is definitely something called seronegative rheumatoid arthritis, which is so hard to diagnose. And rheumatoid factor will be negative, anti-CCP will be negative, but they act just the same, And when we talk about, double-stranded DNA, I really think of a more specific antibody for lupus patients, But remember, when we talk about Sjögren's, there's primary and secondary. And secondary Sjögren's can be added on to rheumatoid arthritis, can be added on to lupus, even though I see it more commonly with rheumatoid arthritis. So this could be a patient with lupus and Sjögren's over there. So I think when you have a lupus patient, you could think about they really tend to have more of the positive ANA, which is based upon titer and pattern. And, those lupus patients tend to have more of the anti-double-stranded DNA in those cases. So our question I used, it was probably a combination of having some lupus and having Sjögren's at the same time. Hope that answered your question. For the boards, in the second primary Sjögren syndrome patient vignette with pulmonary fibrosis. Would the board want us to biopsy the lung prior to placing patient on immunosuppressive therapy if that were an option? That's a really good one. Let me just say this. Love your questions, Hala, by the way, very much so. Is that, it's so hard to make a decision of what to do with many of these ILD patients. One of my passions is CT ILD, connective tissue ILD, but we really present those in a multidisciplinary setting with a rheumatologist and a pulmonologist, IR, surgeon. I'm not trying to hide away from the answer, you know what I mean? But you do want to choose what's the patient's age, what's the necessity, what are the side effects. But I will say this, especially when you're talking about Sjögren's, like this patient, especially talking about extraglandular Sjögren's, which isn't as common, and someone where you're going to commit them to systemic steroids or immunosuppression, I would be very strongly inclined to biopsy, and how we do that is also up to debate, whether it's going to be something as simple as doing a bronchoscopy and ruling out infections and other things before starting, or just looking for cell findings, seeing if it's the Pacific predominant, looking for eosinophils to confirm the right answer or not the right answer, or getting transbronchial biopsies. But nowadays, not to get too detailed, there's something called cryobiopsies. And I work with many amazingly smart interventional pulmonologists that will freeze areas and get bigger bites so they could get tissue, and it's minimally invasive and you don't have to go to surgery. So I would say, to answer your question correctly, is that if I was going to treat, I probably would do some form of tissue evaluation, probably through a bronchoscopy, and there's so many options how to do it. But for the boards, I think they will answer the question the way I presented it, to keep it simple. Asymptomatic, doing well, probably would just monitor first before committing someone to immunotherapy. Once again, I gave you such a detailed answer. I hope you enjoyed that, and that's me.